Miller, and I am the Chief Fellow at the Indiana University Hematology Oncology Fellowship Program. Additionally, I am also a cancer survivor. But before we begin, I'd like to take a moment to introduce Dr. McDonald, whom we are very fortunate to have with us today. Dr. McDonald is a board-certified clinical neuropsychologist. She studies the structure and function of the brain and its relationship to thinking and behaviors. She has more than 20 years of experience working on cognitive and brain imaging studies of the effects of cancer and its treatment on brain function. She completed her postdoctoral training and early faculty career at Dartmouth Medical School before coming to Indiana University and the IU Simon Comprehensive Cancer Center in 2007. She is Director of Pediatric Neuropsychology and Associate Director of the IU Center for Neuroimaging. She is a co-investigator on several studies of cognitive effects in breast cancer patients that are funded by the National Cancer Institute and the National Institute on Aging. She is co-principal investigator of the telehealth and memory study, which is examining effectiveness of 2 different therapies for treating cognitive symptoms after breast cancer chemotherapy. She has co-authored more than 100 peer-reviewed articles and book chapters, has an active clinical neuropsychology practice, and is actively involved in teaching and training future clinicians and researchers. Thanks again for joining us, Dr. McDonald, and I will turn the presentation over to you.
Thanks so much, Dr. Miller. All right, let's take the technical moment here and just make sure our things showing up on the screen that should be. Excellent, thank you so much. So hi, everyone. We have many questions that were sent in ahead of time, but I just wanted to mention that there's certainly also an opportunity to submit additional questions as we go along today. And hopefully I'll address many of those questions as I speak, but certainly we have a plan to save some time at the end for additional questions. So I'm going to go ahead and just present a little bit of information. If I could get my slides to advance. There we go. Okay. So why are we having this conversation today? As I think many of you know or have experienced, we hear commonly from patients that they notice cognitive symptoms after cancer and treatment. And I'll talk a little bit more about what specifically patients tell us in just a moment. But as you can see here, the estimated prevalence of those symptoms really ranges. So there have been studies estimating that relatively few patients experience these symptoms, and then studies that suggest that almost everyone does. So that's really quite a range and not terribly helpful for us in terms of predicting who might have these symptoms. And we've also learned over the years that sometimes we can detect changes on our cognitive tests that are noticeable. And sometimes we really have to rely more on what we call subjective cognitive function. So patients noticing concerns or changes in their thinking and learning that when we do formal testing aren't necessarily obvious for us. So it's really important, and we'll talk a little bit more about this, for us to look at both of those things, to look at formal testing that we do in the office, but then also what patients report. And as you can imagine, these concerns can affect lots of things. They affect people's ability to work, they affect quality of life, social relationships, things that are important to people in their daily lives. This is an issue that's really come to the fore over the past few decades, partly because we have bigger survivorship populations. As our oncologists have gotten better and better at treating cancer, we're now looking at these kinds of side effects more closely because they've become an issue in survivorship. So a lot of this literature in this area has focused on breast cancer, and that's where I've done much of my work. But at this point, really, we've studied a lot of different populations, and we've noticed that these kinds of concerns are present in many different cancer populations. And just because something's not listed here doesn't mean the problem doesn't exist. It may mean that it hasn't been studied yet or hasn't been recognized yet. And what I really want to emphasize throughout my remarks today is that individual difference is incredibly important. So I'm going to make some general statements based on the literature, and that literature is mostly on average, this is what we see. That can't tell us what any given individual experiences. So it's really important for us to, as clinicians, to listen to our patients and treat them based on what they're reporting to us. Part of that has to do with the really broad differences that can come up for different cancer types and different treatment types. So for example, patients with a primary brain tumor are going to have cognitive symptoms that may be related to the tumor itself and its location and surgery to remove it. And that could look very different from what a breast cancer patient who got chemotherapy experiences from what a breast cancer patient who got only hormonal therapy experiences, or from what a breast cancer patient who got both of those treatments and then some biologic treatments experiences. So it's really important to consider that one size does not fit all here. I'm also going to put a disclaimer here, which is that I am constantly telling people not to use the term chemobrain, and here's why. Even though that's going to be the focus of our discussion today. We know and have learned now over many different studies that chemotherapy is not the only cause of these cognitive symptoms, but it is one of the things that we've spent the most time studying. So we know the most about it at this point. But we know that patients who never get chemotherapy can have symptoms, partly because there are some changes related to the cancer disease process. So even before systemic treatment, a higher percentage of cancer patients have lower cognitive functioning than we expect. And we think that's related to the cancer disease process. And again, for patients with primary brain tumors, that's particularly true. We know that patients who get brain radiation or who get endocrine therapies or anti-angiogenic treatments can also experience cognitive symptoms related to those treatments. And there are, when I started this work 20 years ago, the only treatments really in the cohorts we were studying were chemotherapy and tamoxifen. And now there's a universe of other treatments. And so we don't know a lot about all of these treatments in terms of what effects they may have. So there's information we just don't have yet. In the literature, and this is sort of where I live on a research basis, we've really moved away from this term chemobrain or chemofog. So these are the other terms you may see out there when you're looking for information. CRCI, CRCD, sometimes CACD. These are just terms reflective of that broader perspective that the cancer process itself, other treatments are relevant and important for us to consider here. So these are the kinds of symptoms that as a neuropsychologist, as a clinician who really spends my time with patients talking about their thinking and learning and what are they noticing in those domains, these are the things that I hear about most commonly. So learning and memory is a big one. Learning new tasks, remembering things people told them, remembering things they need to do. Various aspects of attention, being able to stay on task, feeling more distractible. What we call executive functioning, and this encompasses a lot of different things, but among the things I hear most about from patients are what we call working memory, which is that ability to sort of keep information in mind while you need it to do something. Also difficulty with multitasking or switching rapidly between tasks, things like that. And then just how long it takes to do something. So patients will say that they can learn new tasks, they can complete tasks that they could do before, but it just feels like it takes longer, or like it's more cognitive effort, like they're just having to work harder to complete the task. There are other cognitive domains that in the literature have been reported, so I just mentioned that here, but most typically, these are the things that I hear most about from patients. And then this slide is really, there's so much variability here. So on average, patients report the most concern, the most significant symptoms during chemotherapy and in that sort of nearer term, weeks to months after treatment completion. And for most individuals, they notice improvement in these symptoms over time. Having said that, not everyone experiences symptoms at all. And not everyone notices that improvement over time. So there's an extensive literature at this point demonstrating that probably a subgroup of patients experiences persistent symptoms. And by persistent, I mean this can be up to years after. So there are now a couple of studies looking at cancer survivors 10 to 20 years post-treatment completion and noticing on average lower cognitive functioning. Any given individual in that group may or may not have symptoms, but on average, we do notice some persistence of symptoms over time. The next question, of course, is so how bad, relatively speaking, are these symptoms? And it's really important to recognize for us as clinicians when we're talking to patients about this, that we're not talking about dementia here. We're not talking about that severe cognitive dysfunction so that people can't do things in day-to-day life. So in overall clinical terms, we're talking about relatively mild cognitive changes. However, for any given individual, those mild changes can be very frustrating. And so we need to have that balance between understanding that we're not talking about that severe cognitive dysfunction that we see in things like Alzheimer's disease, but that doesn't take away from the frustration the individual patient may be experiencing in not being able to do things as well as they could before, or in noticing changes in their attention or their memory. I have here that these changes can be so subtle that as a neuropsychologist, when we do our testing that we do, which is quite extensive, things may look generally pretty normal relative to what we expect for someone's age or their educational background. And there are pros and cons to that. On the one hand, we can reassure people and say, this is not severe dysfunction. This is not dementia. On the other hand, we really do want to emphasize, it's not that we're minimizing what you're saying. It's not that we don't believe you that you're experiencing change. It just means that our tests may not be sensitive enough to detect the kinds of things you're experiencing. And this goes back to what I was saying before in terms of we need both those objective tests, but also patient report of what are you noticing, what's going on in day-to-day life. That's also important in terms of whether or not friends or family members notice these changes. Patients may find it really frustrating that they're noticing differences and others, aren't seeing those changes. So again, it's just really important to listen to what our patients have to tell us. I'm going to spend most of the rest of the talk just talking about what can we do about these symptoms. So you can see that my first bullet point is there's not an easy answer. I don't have a magic solution here, partly because we're still researching and studying options. I've listed here, and I'm going to talk about a few different methods to address these symptoms that have been studied in the literature. Most of this work has been done in cancer survivors who have completed treatment, but there are some studies going on now where researchers are looking at if we implement a treatment during chemotherapy, for example, does that help prevent these problems? So the area where there's the most good data is on cognitive rehabilitation strategies, and these can really cover two different kinds of approaches. One is called skills training, and one is called compensatory strategy training, and I'm going to talk about both of those. Really important as part of these approaches is education about what's normal brain function, what are normal memory failures. We all have normal failures in daily life. We forget what we went into a room to do. We were going to do something and then we lost track of it and we remember it later. That's normal. And so it's important to understand what's normal and not to worry about and what's not. And then some of these interventions are offered as a group approach and some are individual. So skills training is what people might be familiar with in terms of some of these computerized programs that get marketed. So I have some examples here, Brain HQ, which is by Posit Science, Lumosity, CogMed. These are what we call drill and practice approaches, where you practice a skill over and over again and hopefully get better at it. The evidence is mixed on whether or not these are really helpful. In some studies, if you do something that practices speed of processing a lot, you might get faster at that task, but that might not translate into faster completion of tasks at work. And so there's kind of mixed evidence on whether or not this is useful. What there's better evidence for is what we call compensatory strategy training. And this is typically thought of as a form of what's called cognitive behavioral therapy. It's a form of psychotherapy. And what the goal of this approach is to learn strategies to work around these areas of weakness and to also manage other really important factors. So learning how to pace yourself, how to reduce fatigue, how to reduce distractions in what you're doing, how to manage your time and be more organized, how to use calendars or planners or other tools to function more effectively. So this isn't skill rebuilding necessarily, it's using strengths that you have to work around areas of weakness. There's a lot of good data that these approaches work. It's one of the areas where we have the best data in the field. The problem is that these are not interventions that are readily available. There's just not a lot of people doing this kind of work. We really hope that more people start doing it in the future. For those looking for this kind of intervention, the most likely practitioners are going to be either clinical psychologists or neuropsychologists. Sometimes occupational therapists or speech language therapists do this kind of work. But what one would be looking for are folks who advertise that they do cognitive rehabilitation or cognitive remediation. And the nice thing about this kind of approach is that kind of therapy is typically covered by insurance policies. As I mentioned before, the evidence for computerized cognitive training is not as strong. And unfortunately, these are not typically covered by most insurances. The other big caveat I have to those is that there are a lot of different kinds of practices out there marketing various cognitive interventions without any evidence that they work. And so this is something that can cost a lot of money out of pocket and may or may not be useful. The other area where we have the most data is physical activity. And I'll mention in a moment, we think physical activity is helpful in any number of ways, but there is specific evidence in cancer survivors that we can see improvement with exercise in both objective and subjective cognitive function. There are some animal model studies where They've shown that exercise actually prevents some brain changes that we know are related to cognitive changes. And a few different types of exercise have been studied. So aerobic exercise has definitely been studied, but it doesn't have to be aerobic exercise. Yoga has also been looked at a little bit, Tai Chi a little bit, and even in the sort of more physical exertion, even things like, regular walking, it doesn't have to be really extreme exercise, has been shown to be helpful to some degree. This is still a developing area though. Many of these studies have not had really great comparison groups, so we don't have as much data as we would like in terms of the effectiveness, but it's really promising. And there is more work ongoing now. Medication is an area where there's really nothing recommended right now that we are confident will be helpful. So as you can see here, the National Comprehensive Cancer Network really says this is the last line of treatment because we just don't have good data that it's helpful. The drugs that have been studied in more than one study have been methylphenidate, so Ritalin is another stimulant medications, and modafinil. And there are a couple of studies suggestive of effectiveness for these medications in cancer survivors. But as I mentioned, it's not strongly convincing data, or it's not really big improvement. So this is really not considered a primary treatment recommendation. And there are a few other agents currently being studied, but again, nothing out there right now that we can recommend strongly. And then finally, there are a few other sorts of treatments that have been studied. Listed here: mindfulness-based interventions, acupuncture, and by this I mean there's sort of one or two studies out there, but nothing convincing and compelling yet. We do know it's really important to manage other things that we know can affect cognition. So depression, anxiety, high degrees of stress, all of these things can affect our attention, our memory, all of those functions. So it's really important to manage those symptoms. Those symptoms don't cause the cognitive problems related to cancer and treatment, but they certainly can make things worse. And so it's really important to focus on tending to those things if they're relevant for someone. And then just across the board, anything that's going to help with a healthy lifestyle is going to be helpful for not only cognitive functioning, but for all the other potential effects of cancer and treatment that can affect someone's quality of life. So healthy diet, exercise, sleep, having enjoyable leisure activities that are cognitively challenging, we know is helpful, reducing stress, maintaining good social networks, all of these things are important for general health as well as for cognitive functioning. And then finally, there are lots of things we don't know yet. So we have a lot of work left to do. One of the really important areas of work right now is trying to understand who's most at risk for these symptoms. So some of the work our group and others have done has shown that individuals who are older at diagnosis, who have lower cognitive abilities at diagnosis, and there are some genetic and sort of frailty risk factors that we know are related, but that doesn't tell us for any given individual if they're going to have symptoms or not. So it's really important for us to keep working in this area. We're also not sure if having a cancer and treatment history puts somebody at increased risk for dementia or not yet. There's literature working on this. Right now, we have some evidence that actually a cancer history is protective from Alzheimer's disease, but also some evidence in the other direction. So we really don't know the answer to this question yet. As I mentioned earlier, trying to parse out effects of different chemotherapy types or different treatment types is really challenging, partly because people get so many different kinds of treatments. So we really don't have a good answer there in terms of whether this kind of chemotherapy or this kind of chemotherapy is more likely to cause challenges. The data that has looked at different agents so far has shown some degree of change for every agent that's been studied. But again, we just don't have enough information because these regimens are so complicated and typically multiple medications are used. And then the last slide I'm going to show you here is that there are just a lot of biological mechanisms that we think are related potentially to these changes. If you look at this slide, all of these different proposed mechanisms have been studied to some degree, and there has been some evidence found to support all of them. So what we know is that this is a really complicated area, and there's not one answer, and treatments are really going after a lot of, or attempts at treatments are really going at a lot of different approaches to try and figure out which of these mechanisms we can address. I understand that this talk will be available online, so I just included a few links here to sort of general information that folks want to go back and look at the talk again, they'll be able to go to these links. And then finally, just wanted to mention, just as an example, ongoing work that our group is doing. So we're conducting right now a study of a cognitive rehabilitation approach that we have preliminary data we think is likely to be helpful. So this is just an example of one of those cognitive behavioral therapies focused on strategies. So our group here at IU and at the University of Pittsburgh are comparing, as Dr. Miller mentioned, 2 different therapies. This is a telehealth delivery study. So one of the things that we really want to be able to do is to reach patients wherever they are and make it easy for them to participate. So our study can be done almost entirely over video conference or over the phone. We have an optional MRI component that requires folks to come in person for 2 visits, but everything else can be done over the phone. And in our study, we're focusing on breast cancer survivors who have had chemotherapy. Hopefully we can demonstrate that these treatments work and then broaden this to other cancer populations in the future. So I'll stop there and then want to leave time to take any questions that we have.
Okay, great. Thank you for this great presentation, Dr. McDonald. So we've already had quite a few questions that were submitted prior to this presentation. So I'm going to kind of go through some of them to ask that weren't covered in the presentation. And of course, if anybody who's watching this live has any questions, they can submit it, and we will also try to get your questions answered. So I think one of the first questions that I have is that, you mentioned that there may be a small population of people where their long-term effects with I'm going to refer to it as Chemobrain just for ease, but where the long-term effects of Chemobrain where they don't necessarily get better. Have we identified any people who may be more at risk for the side effects of the Chemobrain not getting better over time? So what I mean by that is just in a broad sense, like men versus women, older age, anything in particular that might not necessarily be able to be changed, but that might make people more at risk for having these long-term effects that don't necessarily get better.
Yeah, it's a really great question. And the answer is honestly that we don't really know yet, partly because the studies to answer that question don't exist yet. So there's a couple of ways this work gets done. One is what's called a cross-sectional study, where we just look at people who have had cancer and treatment. And another is a longitudinal study where we get some set of assessments before cancer treatment and then follow those people over time. And if you ask this question of those 2 kinds of studies, you get different answers. So if you study patients only after they've gotten treatment, you see more severe, more significant cognitive change than if you look at how were they before. So it's really important to consider what was somebody's functioning like before cancer treatment, so that you have a better estimate of whether or not they're experiencing change after. So we've learned that really longitudinal studies are better for this. And the longitudinal studies that are out there right now have really only followed people a few years after treatment so far. This is work that's evolved over time. We don't have those super long-term survivor studies yet to answer that question well. We're starting to in pediatric cancer populations. So there are now individuals who are treated as young children for example, for leukemia, who are now adult survivors, and we're starting to be able to answer that question. But that's the differences between cancer populations are also hugely important here. So that's a population that gets a different, a totally different chemotherapy regimen than, say, a breast cancer patient, an adult breast cancer patient would get. So the answer to that question is almost certainly going to be different for different cancer and treatment types. And the answer for many cancers and treatment types is that we just don't have data far enough out to know. As I mentioned, one of the things we do know is that folks who are older at diagnosis, who are lower functioning at diagnosis, are more likely to experience problems in the first place. And it wouldn't surprise me if we learn that those are also folks who are most at risk for persistent deficits, but we don't know the answer to that yet.
And then, some of our cancer patients, unfortunately have to be on long-term chemotherapy. So they don't necessarily get a break or get to finish from the treatment. Is there any ongoing research or any studies that's looking into how to help prevent or kind of combat these Chemobrain symptoms in people who are planned to be on chemotherapy treatments or hormone treatments long-term? So like breast cancer patients can be on hormonal therapies for up to 10 years.
Exactly. Yep. I think that's where some of these interventions, and there's really only a handful of studies that are doing this work, and some of those are ongoing, where the studies that are trying to do an intervention starting during chemotherapy, I think will be really informative for us. Those are ongoing studies now, so we don't know the answer, But the idea behind trying to do an intervention or administer a medication or whatever during treatment is hopefully to try and either minimize or prevent some of these concerns. So that's definitely an active area of work. There's a little bit of literature in some older studies in children treated for leukemia, where they did do, for example, an intervention designed to help prevent learning disabilities that did seem to be beneficial. Those kids did better. So there's some data to suggest that approach might be useful, but in many populations, we don't know the answer yet. As I mentioned, really the biggest areas where this work has been done has been in childhood leukemia, in adult breast cancer, and in brain tumor. For a lot of cancer populations, we don't have a specific answer yet. There's no reason to believe an intervention that works in one type wouldn't work in another, but we just don't know the answer yet. So our hope is that the intervention that we're doing, these other interventions that groups are doing, that they would be generalizable to other cancer populations. But first we have to start somewhere and demonstrate that they work somewhere first.
The next question I have is kind of relating to things that other cancer patients can do to help with Chemobrain. So you'll see or read online, or, people will send cancer patients articles, things like that, showing, hey, if you take this vitamin, so like omega-3 is supposed to be good for your brain. If you take this vitamin, or if there's some supplements that are out on the market that are supposed to help with brain function. Is there any information or anything that shows that there's any specific diet, any specific vitamin, or any specific supplement can help with Chemobrain symptoms?
So this is the great thing about the internet, right? Is we can get tons and tons of information, but the bad thing about that is that lots of that information isn't really well supported by evidence that I as a clinician would use to recommend something to somebody. So generally speaking, I've not seen any convincing data around supplements, and like we talked about medications already, except to say that what we, and this also changes regularly too, right? The kind of diet is told to be healthy, that changes, that's evolved over time. The best literature that I'm aware of so far in terms of general cognitive health has really most recently focused around sort of a more Mediterranean diet approach, just in terms of promoting general health. My honest answer to that would be for patients to talk to their primary care physician or their oncologist about what is the data for these things in terms of my overall health. As I mentioned, things that are going to help overall health are going to help cognition. So even if they're not specifically targeting cancer and treatment related symptoms, they're going to be helpful for your overall health. And that's really important for our thinking. And it's also really important for preventing other cognitive problems of aging, like dementia. So things that are going to support your general health are going to support your cognition. But I would absolutely talk to your primary care doctor and or your oncologist about things that you're considering implementing. I think there are a number of things that may not hurt, but also may not be tremendously helpful. And so then the question is whether that's a good use of your resources, if they're expensive or something like that. So that would be my honest answer to that.
And then I think this question is kind of going back to the very basics of Chemobrain. So in my own personal experience of having gone through chemotherapy, there are sometimes just some things that are almost impossible to describe. You try to use your best to try to use words to describe what you're experiencing, but it just doesn't come out the way that you want it to. And you talk to other cancer patients who are going through similar treatments, or other cancer survivors, and they automatically know exactly what you're talking about. You don't even have to explain it. It's a common, like, shared experience. So for me personally, when I think about what Chemobrain entails, the way I kind of envision it is, let's say that you're in a field and you're given a map with directions to get back to your house, but you're surrounded by a dense layer of fog and you can't see 5 feet in front of you. And so you can get back to your house, you know how to do it, but it's just that this fog is just making it much more difficult. And everybody experiences their symptoms differently. But are there any words or descriptors that patients can use, that are kind of known, that patients can use to really kind of say, this is what I'm feeling, or to help them advocate for the kinds of symptoms that they're feeling, not only with their family, but also with their caregivers, with their medical team, to kind of describe these difficult sensations that are hard to describe.
You know, I mean, I really want to emphasize one of the things you touched on, which is that those support networks of other cancer survivors, I think, can be so helpful in terms of that shared experience, because it is really challenging for, especially as I mentioned earlier, for family members who may not really notice these changes to understand what people are going through. I think you've identified a problem that's really challenging for clinicians. So, you know, when it's a clinician who's worked in this field for a long time, I think they're more likely to go, yep, I've heard patients say things like that before. Exactly as you described. You described like a fog, or just, I have to work so much harder, or I'm really exhausted at the end of a day because it's just everything so much harder, even if it wasn't like, you know, a day that would have been particularly hard before. But I think honestly, just describing what you're experiencing, hopefully, as over the years, it used to be the case that these symptoms were really sort of dismissed before we really had the data to say, no, this is a real thing. It was very commonly sort of, oh, it's just that you're anxious about your cancer. It's just that you're depressed. It's just that whatever. We really now understand that there's a brain basis for these things that's different and independent from depression or anxiety, or just being incredibly stressed about being told you have cancer, right? All of those are real things too, but that's not what accounts for the cognitive change. I think clinicians are more aware of this now, which I think helps in terms of hearing a patient say, I'm having these symptoms, and hopefully having a light bulb go off in their head. Oh, maybe I should refer them for more evaluation, or you know, look at what options are. I don't know that there are necessarily specific phrases, but the kinds of things you described, and like I said, the things I hear from patients mostly are, I just don't feel like my memory is good, or I can't multitask. Those are things that I hear commonly that are to me, okay, I wonder if this is related to the history of cancer and treatment. The other thing that I think about as an example to family to maybe help them understand is hearing loss. So, you know, people get really super frustrated when they're talking to someone in their family and they don't get a response. And it's, you know, it's maybe that they weren't paying attention to you, or maybe it's that they couldn't hear you, and sort of trying to convey that information. It's another sort of maybe more accessible to people where they might recognize, oh, of course, that could be the explanation for why someone's having a challenge. I think it's sort of like that. It's something that unless you're experiencing it yourself, you really don't know how it's affecting the other person's response. But just as you said, that doesn't mean it's any less real. It just means that we sort of have to take on faith the patient's report is important to us.
And have you, in your clinical practice, have you noticed that there's any best way for patients, you know, not necessarily to describe, but also to show the symptom severity that they're experiencing? So the thing that I think of is, you know, sometimes we have patients do like diaries, logging things, specific things, tasks that they're struggling with, or, and, you know, how it's impacting, you know, their quality of life and their day-to-day functions. Have you found that to be, is that beneficial, or is there any sort of strategy that that has been found to be helpful to kind of give people more insight to what patients are experiencing when they're going through Chemobrain symptoms?
I think those examples are the most helpful thing. What are the challenges you're experiencing? So like specifically, like I tried to do this kind of task at work and this is what happens. This is what I notice. Compared to if I tried to do this kind of task before, how I would have responded, how I would have felt. Jotting down those examples is really helpful, particularly if, you know, we all lose track of things. Like I mentioned, we all have these sort of day-to-day memory failures. But if one of the areas someone is concerned about is memory, you go into a doctor's appointment, you may feel pressed for time, and all those things you wanted to say may like pop right out of your head. So jotting them down is a great idea, because then you have those examples to provide to the clinician, and they can get some clarity on whether or not, oh, you know, that's a more typical thing that we would expect, versus it's something more of concern. The other thing I think is really helpful is to also reflect on, when you notice those kinds of concerns, what else is going on? You know, is it that you know, you've got a lot of young kids and they're also demanding your attention at the time you forgot something? So that suggests to a clinician, okay, that's a more normal day-to-day life thing. When we've got, multiple demands on our attention, we don't learn things as well. So to the extent that you can be reflective on what else is going on, or there was a particularly stressful thing in your life happening at the time you notice these changes, that just all that information is useful to clinicians in terms of how they think about these changes and what they're likely to reflect, whether they're more likely to be related to cancer and treatment versus something else.
And then, you mentioned that we had talked a lot about the different ways that Chemobrain can affect people's ability to function. But do we know if there's any data or anything about the impacts of Chemobrain on mental health?
So there's absolutely an intersection between cancer and treatment, and then separately between cognitive functioning and mental health. So we know that cancer patients just generally are at increased risk to some degree for things like anxiety and depression, partly related to the stress of a cancer diagnosis and everything that comes with it. We also know that individuals who are struggling with their cognition due to cancer and treatment related effects, or due to any number of other factors that affect cognition, are at risk for those same increased mental health concerns, because that all of those things can come with feeling like you're experiencing cognitive changes. And so that is absolutely a risk. It's not specific to cancer and treatment necessarily. Any disorder, any medical disorder, any other cause of cognitive change can put someone at increased risk for mood symptoms or anxiety. So it's part of why I mentioned it's so important to monitor and treat those things independently. So if someone is having clinically significant depression, if they're having clinically significant anxiety, that's a really important thing to treat, both in terms of mood and quality of life from that perspective, but also because those symptoms can then have this sort of vicious cycle effect on cognition, where they can sort of make cognitive problems worse because of level of depression or anxiety. So it's really important to treat those things as well.
And then we've also actually had some questions from healthcare workers. So if it's okay, I'd like to ask you a couple of questions too from them. So one of the things is, how can not only the medical team, but the caregivers and families of the patients, how can they best, support the patient who is going through chemotherapy, suffering the side effects with the Chemobrain? What are some ways that we can best support these patients?
I mean, I think you touched on one of them earlier, which is essentially to believe them, to take them at their word. So as I mentioned, years and years ago, this phenomenon was sort of first really recognized in breast cancer patients, and really, like I said, dismissed as oh, it's just that you're depressed, it's just that you're anxious, it's just that you're quote unquote hysterical. We know that's not the case. And so really registering that these are meaningful symptoms that are affecting someone's life. And even if they're not so severe as dementia, that doesn't mean it's any less frustrating to feel like you're not as sharp as you were, or to feel like you can't do your job as well. And so sure, as you would be supportive related to the cancer itself, being supportive of these symptoms, even though you can't see them, right? This is a challenge for folks with many medical disorders where there's not an obvious physical symptom. When somebody looks normal, and maybe when they're done treatment and they're healthy again, or they're in remission, it's easy to forget that there may be some persisting things that they're dealing with. And there can be other health effects that are persistent for cancer survivors too. Cognition is certainly not the only one. But just sort of trying to be empathetic and understanding, as a clinician, I would say, really talking to them about what's sort of normal, what's not beyond normal. If you're in doubt, referring them to, say, a neuropsychologist or to a psychologist to look at, is there a mental health component to this, or is there a cognitive component to this that's clinically significant? As I mentioned, sometimes that feedback, if tests are generally normal, can be reassuring. It may be frustrating, and it may be a change from your previous functioning, but it can be reassuring to know, okay, you're still broadly normal. What are some strategies you can use to sort of work around these things? Because there are strategies that you can use to work around these things. Many of us can get by day to day without using a planner, but when you start using a planner, it may really help, and you may feel like these effects are not negatively affecting your ability to do what you need to do. So honestly, believing your friends or family members, and then helping them sort of find resources, I think are two really important ways to be supportive and helpful.
Okay. And then I think we have two more questions. We have 5 minutes left, so we'll try to get through them. I think one of the questions is that sometimes, patients, when they're going through chemotherapy, They can be on a lot of different medications. So sometimes the nausea medications like Zofran or Compazine, or sometimes people who require Ativan, they can also make patients feel sleepy or fuzzy. And, sometimes the effects of radiation can also cause people to feel fuzzy as well. So is there any way to tease out or kind of figure out how to break apart symptoms of Chemobrain versus side effects from medications or other ongoing things?
Really, the best way to know, honestly, is to see if those things persist once that medication has been discontinued, or that immediate circumstance has sort of been removed from the picture in the moment. And that's part of why we think symptoms are sort of most noticeable during and immediately after treatment. Is there's some period of time where we just sort of have to wait and see what persists after that treatment is not part of the picture anymore. We really don't have a way to disentangle. As I mentioned, given the complexity of treatment regimens these days, we really don't have a good way to disentangle effects of different treatments from each other, except to monitor function over time and see if there are improvements once something has been taken out of the mix.
Great. And then one final question, which I think this is very relevant to kind of today's practice. So, medicine has a lot of new medications. So targeted treatments, one of the big ones is immunotherapy that has been on the market. So I know we have some, we have information about the effects with chemotherapy. And you can correct me if I'm wrong, but what about with immunotherapy? Are there any studies looking at the difference in cognitive functioning in those with immunotherapy? I'm not sure, but I thought I heard that at IU we were going to be opening a study to look at that. This may have been the mental impacts, but looking at the long-term impacts of immunotherapy on function. But what is, do you know if there's any data or any information out there about this?
I'm not aware of any yet, but I'm sure this is an area. I mean, I've talked with colleagues. I'm sure this is an area that will be studied. I mean, this like I mentioned earlier, the landscape in terms of available treatments has changed so much over the past 20 years in terms of all of these just different approaches as we've moved towards personalized medicine, really trying to tailor treatment to any given person. It's going to be really important to get information about all of these modalities to know, but it is going to be really challenging to do because they're used in combination or they're used in a very tailored way for this person versus that person. So for us to make general statements across a group is going to be really hard. To me, as a neuropsychologist, it's always most important to look at an individual's presentation. What is this person reporting in terms of symptoms? What do their test scores look like? Because in terms of helping that individual, that's going to be what I need to know. We don't have good data. The data we have most right now is on chemotherapy and radiation, and to some degree hormonal therapies, although there's much less data for that than for either chemotherapy or radiation. And for everything else, we're still learning a lot at this point, but we need to know that information. And it's really important, I think, also to underscore here that we're talking about an important side effect, but a side effect because cancer treatment has gotten so much better and we have survivors where now we're talking about side effects. So it's really important to know about these things, to be making informed treatment choices. But it's also really important to emphasize that it's in some ways a fortunate thing that we're dealing with this side effect, because it means that people are surviving their cancer in a way that they weren't before. And so that's really important to incorporate into all of this, is to not lose sight of the importance of having treatments that are effective and life-saving in terms of cancer. And now our next challenge is, okay, so now how do we minimize the side effects?
Okay. Well, those are all the questions that I have for you today. I want to thank you again for giving this lecture, and I want to thank everybody who was able to join the live stream. So I hope everybody has a good Memorial weekend.
Thanks so much. I really appreciate it.